Good evening, everyone. I've been asked to talk for 45 minutes to an hour or so about bundle branch blocks, following a few other webinars I've done on introduction to ECG and some AV blocks. And so I've termed intraventricular conduction delays, not to try and sound clever, but because I think in addition to talking about bundle branch blocks, it'd be useful to go over some fascicular blocks as well, which kind of fit in the same overall subject heading. So for those that haven't seen one of the webinars before, my name is Silas. I'm a specialist paramedic in critical care. And in addition to my normal role, I'm quite interested in medical education with a professional interest in ECG stuff, hence me being here. My day-to-day job involves working on a car and responding to critical care type jobs and supporting other crews. So I see quite a lot of cardiac patients and do a lot of ECGs in that context. But I also work occasionally on DCAs responding to normal ambulance jobs, if you can call it that. And so I have an interest in that area of kind of risk stratification and like cardiac condition diagnosis and ECG in that context. So that's my kind of clinical background. I also have my own kind of platform where I've got this pre-hospital podcast and kind of do occasional webinars and bits myself as well. So if you are on Twitter, I'd appreciate if you could go over and have a look at that, that'd be great. And if you're interested, give us a follow. And in terms of the pre-hospital podcast, that's something I do monthly. It's a free podcast, and I just chat to a different expert every month about something within the specialty of pre-hospital care. And our website is prem-ed.com. Feel free to check that out also. And so this evening, I've been asked to talk about bundle branch blocks. As I said, I'm going to broaden out a little bit to include fascicular blocks and combinations of the two or three. And to do so, I've just got this agenda here in which we'll go over some definitions that I think are useful for the context of the presentation. A look at the kind of etiology and kind of causes of these problems. And then I'll do some kind of whiteboard drawing stuff to dig into the anatomy and physiology of the His-Purkinje system, of the part of the conduction system. And then we'll talk kind of in order, bundle branch blocks and then fascicular blocks, and then the slightly more complex things. And have a little look over the guidance that fits around that as well, so that we have an idea of how to manage these patients in practice. And so in terms of learning outcomes then, I can see from the comments it's a fairly mixed group. Clearly my background is pre-hospital care, and so that's kind of the focus of this presentation. However, it should apply to kind of all of emergency medicine, one would hope. And so the learning outcomes from me, I think the really important things are to understand clinical correlation, and so how to fit this. I think it's fairly pointless doing an ECG without it being in clinical context, because the answers it gives you are essentially not particularly meaningful. And so I think an important learning outcome always is to understand how these ECG patterns and interpretations fit into our clinical diagnosis or differentials. And then to understand the anatomy and physiology of the bottom part of the conduction system and how that relates to cardiac function. And then obviously we'll learn to recognize left and right bundle branch blocks on the surface ECG. And I've put in brackets there because I don't think it kind of, depending on your level, you may hopefully go away with an ability to recognize anterior and posterior fascicular blocks as well. And then finally, as I kind of mentioned, ideally we'll have some discussion around management and how to manage these cases appropriately in that clinical context. So some definitions then. There's a few that I think are important, and these are kind of some of the top ones. Obviously, we know we have a conduction system, and we'll dig into that a little bit shortly. But we know that's the system of kind of specialized cardiac cells that follow a certain pattern in the heart, and they conduct electricity in an organized manner through the heart, allowing the myocardium to contract in this organized manner and be most effective. And so the term intraventricular, where I've said intraventricular conduction delays for the title of this presentation, that just means that it's situated or contained within the ventricles of the heart. It also refers to ventricles elsewhere in the body, but obviously in the context of today, we're talking about the heart. And so the aspect of the conduction system that is intraventricular is from the bundle of His and down to the Purkinje fibers, and we'll draw that in a second. But so at the top, between the right atrium and the right ventricle, we know we've got the AV nodes, and from there, the bundle of His comes off, and then that separates into two bundle branches, which we can see are a division or offshoot of nerves from the bundle of His, and so bundle branches, and then they kind of extend into what are called fascicles. And fascicle is just the term for a bundle of structures, which is what these are. Automaticity we discussed last webinar, but essentially it's the ability of heart cells to spontaneously depolarize. And we'll discuss that a little bit more in the physiology kind of chat, because it becomes important for complete blocks. And a block can mean a lot of things, but in the context of today, obviously it means an abnormal delay or failure of the conduction system. And so that can be either anatomical from degradation of the conduction system or ischemia, for instance, or it can be functional, where the depolarization and repolarization of the conduction system is affected. And so you get a kind of functional block, which can come and go, depending on the context. In terms of some causes then, I've looked at right and left bundle branch block and not the fascicular block specifically, because these are the kind of big ones that we're considering this evening. And so you can see a list there. I'll keep my own face getting in my way. So you can see a list there of the causes of each, and there's some common themes across both. But so if we take the right bundle branch, for instance, we can see that idiopathic fibrosis is a cause, and it can be quite a common one. Things like congenital heart disease can cause right bundle, and so young people may have right bundle and not be symptomatic and be otherwise well, and then it's considered benign. But also it may be caused by ischemic heart disease, as can a left bundle, and we'll dig into that a little bit more as we go through. And then conditions such as other cardiovascular conditions such as PE, which we may not immediately consider with a bundle branch block, and then more chronic causes of right heart changes such as COPD. In terms of left bundle branch block, which is certainly in pre-hospital care has always been taught as the scary one of the two, that can be caused by aortic stenosis, again ischemic heart disease and MI, but also by degenerative disease and other conditions such as hyperkalemia and digoxin toxicity, as we see there. So varied causes of each, and for that reason, and kind of touching on the clinical context thing again, clinical correlation, is that given they've got varied causes, when we recognize that on an ECG, you have to kind of fit it into how the patient's presenting, because there's a big difference between someone who's got digoxin toxicity and someone who's having an anterior MI in terms of their clinical course and what they're required to, what care they require. And so just having a standard treatment for bundle branch block is not sufficient, and it has to be matched with the patient in order to provide the appropriate care. So just before I do start drawing, I'd like to give this analogy of how the conduction system works. And essentially, it's a system of wiring that releases electricity at certain points. And so you can kind of picture it like this Christmas light wire, where electricity, as it's traveling through the main cable of this lighting, is not recognizable. It doesn't cause any light. And it's only when it reaches the actual light, the actual bulbs, that the electricity is released and causes an effect in this instant light. And the same thing happens with the conduction system. So all the time that electricity is traveling through it, it's not being released into the myocardium, and the heart essentially doesn't know it's there. Only when it's released into the Purkinje fibers, which I'll look at in more detail shortly, does it come out of the Purkinje fibers and release into the myocardium and then trigger contraction and pumping of the heart. So it's an important kind of thing to have in your mind. And I couldn't find an exact analogy type picture, but this is pretty close. And so essentially this kind of cable analogy fits in terms of how the conduction system works. And so we have this cable through which electricity travels, and then these fascicles which arise. So if we consider the whole cable to be the bundle of His, and then that separates into two bundle branches, and then that further separates into fascicles. And those fascicles contain a bundle of nerves, which eventually turn into release Purkinje fibers. And the Purkinje fibers innervate the myocardium to release the electricity into the myocardium. And so it's a really the conduction system is a really controlled way of delivering electricity to all the points in the myocardium that we want it, rather than just blasting some electricity at the top and letting the cells do their own thing. And so if I stop sharing this, I'm going to do some drawing here. So like I say, so previously we've looked at the beginning of the conduction system when I talked about AV blocks, and I think there's probably not a lot of point in going over that now. But hopefully everyone is aware that the conduction system starts at the SA node, which spreads electricity through the atria and has this controlled, causes a controlled depolarization and contraction of the atria. And then that electricity is collected in the AV node, ready to pass into the His-Purkinje system. And so what happens if we put an electrode here, so we'll call that V6 electrode. We know that the SA node firing and the impulse traveling through this conduction system is so small, and because it's not released into the tissue, it doesn't cause any sort of deflection on the surface ECG. And so you have just a flat isoelectric line. As the electricity then spreads through the atria, through the myocardium of the atria, we have a P wave. And then we have this pause here, which is often taught incorrectly as a pause in which the AV node collects all the electricity and holds it. And that's not quite true. And what essentially happens is as the electricity flows into the AV node, it flows straight into the conduction system. And the reason we get the pause is slightly different. So for the purpose of this discussion, normally you'd have the pulmonary artery here. However, I'm going to get this out of the way so that we can, where's my other pen? So that we can view kind of what's happening in this interventricular septum with the conduction system. And so coming out of the AV node is this bundle here, which is called the bundle of His. And that's the only thing in normal anatomy that will come out of the AV node and into the interventricular septum. And the other thing to be aware of with this conduction system is that in normal physiology, with some conditions aside, electricity can't pass from the atria into the ventricles. And so there's a kind of barrier of tissue that of cells that don't cause the next one to depolarize. And so the only way electricity can travel from the atria into the ventricles is through this system here. And so it collects into the AV node and then kind of pours into the bundle of His. And then the bundle of His quite quickly separates into two bundle branches. And the left bundle branch here goes down the septum and then up and through the left ventricular myocardium. Hopefully people can see that. And then the other separation is the right bundle, and that right bundle branch again goes down the other side of the ventricular septum and around the right ventricular myocardium. So that's the two bundle branches, and people commonly know that. And the other thing to be aware of is that actually the left bundle splits into two, and they're called fascicles. And so what you have is an anterior and a posterior fascicle. And so this picture that we see here of the left bundle branch, actually from about here down is the anterior fascicle. And if we were to look at the heart in a 3D model, then that anterior fascicle would be kind of around the front of the left ventricle and coming around. And the posterior fascicle kind of goes around the back and has branches out behind the left ventricle there. And so between the posterior and the anterior and posterior fascicle, that's how the left bundle branch kind of delivers electricity into the left ventricle. And the way I would remember that is that because the left ventricle is bigger, it's more muscular, and therefore requires more electricity to depolarize. it requires 2 fascicles to do that, whereas the right ventricle only requires the 1 branch to deliver that. And so what we have is 2 bundle branches which lead into 2 left fascicles and 1 right fascicle, which is actually the bundle branch. And for ease of understanding later on, you can kind of consider them to be 3 different fascicles. So we know a fascicle is a branch of nerves, and so we have 3 fascicles in the ventricles. The other thing to be aware of with the bundle branches and these fascicles is that they innervate the endocardium. And so the energy, so they go on the inside here, so the endocardium being the inner wall of the myocardium and the epicardium being the outside. And the energy is released from these Purkinje fibers into the inner part of the myocardium. And so to recap that, like we said, the conduction system is a network of wiring, essentially, through which electricity travels. But all the time it's traveling through this wiring, it's not causing the myocardium to contract because it's inside the wiring system. Once it reaches Purkinje fibers, then it's the Purkinje fibers release that energy into the myocardium. And that triggers this kind of domino effect of depolarizing muscular cells, and that causes contraction. And so the Purkinje fibers, like I say, innervate the inner aspect of the endocardium in normal physiology. And then that domino effect of cardiomyocytes triggering the next one to decontract spreads from the inside of the myocardium outward. So the energy goes outward like that. And so the wave of current that we see on the ECG is from electricity flowing toward the electrodes during the depolarization phase. So if we look at the physiology of this then, so this is the kind of anatomy. In terms of the physiology, the Purkinje fibers from the left, so the left bundle branch is a little bit more complex. It has Purkinje fibers up in the interventricular septum that release energy into there. It also has Purkinje fibers in the anterior and posterior fascicles that release energy at their distal end, electricity into the myocardium. Whilst the right bundle branch only doesn't release energy into the ventricular septum, but releases this electricity through the Purkinje fibers at the distal end of the branch. And so what we see in terms of contraction of the heart is that this electricity, or let's have a look at the waveform actually, and then we'll talk about contraction. So this, if we go back to the waveform, we've discussed the P wave here. This pause, so we get this pause of isoelectric line of no electricity, of no electrical activity at all. And that's when the electricity is traveling through the AV node, through the bundle of His and into the His-Purkinje system. And so this, you get a delay here because the electricity is traveling through the system, but not into the myocardium. The first thing we see in these kind of left lateral kind of electrodes then is the energy being released from the Purkinje fibers in the interventricular septum. And that energy flows from the left bundle towards the right bundle across the interventricular septum like that. And what we get therefore is a negative deflection as it travels away from the electrode that we're looking at. And so in V6 this would occur, but in V1, which might be over here, we wouldn't see that negative deflection. And so the next thing that will happen is the electricity will quickly, or fairly soon after that, electricity will be released from the Purkinje fibers in the left ventricle. And that will cause a wave of electricity, like I say, from the endocardium towards the epicardium. And given that there's a lot of electricity, a lot of amplitude, because of the size of the left ventricle, we get a big spike, which is a positive R wave. At the same time, electricity is released into the right ventricle, and that flows again from the endocardium to the epicardium in this direction. But that's away from lead V6. And so that would be seen as a negative deflection on V6. However, because they occur at the same time and the left ventricle is bigger, and so it recognizes more amplitudes, and it's closer to the electrodes, whatever's happening in the right ventricle is dominated by what's happening in the left. And so the net effect is a positive deflection on the ECG. The right is a little bit slower, and so often what we find is a small negative deflection. Once this left ventricle is finished depolarizing, we get a small negative deflection, which is kind of the last phase of the right ventricle depolarizing before we get back to the isoelectric line. And then we get another strip of isoelectric activity in which the ventricles have done their thing, all the cells have depolarized, and then they pause for a short amount of time, and then they repolarize, ready for the next contraction. And that repolarization is shown as a T wave, which looks something like that. So the thing to understand about a T wave and why it's positive is so it's important to understand that. And so we know that electricity traveling towards an electrode causes a positive deflection on the ECG. And so in normal physiology, when electricity is released into the endocardium and moves out to the epicardium towards the electrode, we get a positive spike. And so this repolarization phase is the opposite of depolarization. And so if repolarization is heading towards an electrode, it should cause a negative spike or a negative deflection. However, what we see is a positive one, and it's important to understand why that is, because it explains a bit more about why we get T-wave abnormalities. And the reason it's positive and not negative is that whilst the depolarization wave goes from the endocardium to the epicardium, the repolarization wave happens to go in the opposite direction. And the analogy I like to talk about is that of a line of dominoes. And if you set up a line of dominoes, you can flick the first one and that will automatically cause a wave of dominoes falling over one after the other. However, you can't stand the last one up and expect them all to stand themselves up. We have to do that individually. And the same can be said of cardiomyocytes. Each of them has the innate ability to cause the next one in front of it to depolarize and contract. However, they all have to repolarize of their own accord. And it just so happens that repolarization wave occurs from the epicardium to the endocardium. And so what we have is a kind of double negative where the depolarization wave flows towards the electrode and the repolarization wave flows away from the electrode. And so we get a double negative and an overall positive T wave, which is termed concordant. And concordant is an important term. And that means if the T wave is in the same overall direction as the majority of the QRS complex. And so in normal physiology, if we have a positive QRS complex, we should have a positive T wave. And similarly, if we talk about AVR, for example, where all waves are negative, a negative overall QRS complex should be followed by a negative inverted T wave in normal physiology. And that's expected, that's concordance, and that's appropriate. People will know that sometimes in ischemia, where this repolarization is not working normally, you might see T wave abnormalities such as hyperacute T waves or T wave inversion. And essentially what that is showing us is that the T wave, the repolarization part of the cardiac cycle is dysfunctional. And so it's causing those T wave abnormalities. So concordance is what we're after. So if we then talk about bundle branch blocks specifically, cool. So we know these are the bundle branches, and we're talking about bundle branch blocks, and so it's important to kind of understand how that occurs. And what essentially can happen is, in the same way as the rest of the conduction system, you can get a functional or an anatomic block that's causing that electricity to not be able to travel properly through this conduction network. And so some examples of causes may be, like we said, that idiopathic fibrosis, where just with age or for whatever reason, the conduction system kind of breaks down, that wiring breaks down and stops functioning properly. And so you might get the right bundle stop working. And so electricity is only traveling through the left anterior and posterior fascicles. Another reason might be an MI. And that's important because we know that there's a system of coronary circulation. So you've got the left anterior descending, the left circumflex, and the right coronary arteries. And the majority of both bundle branches are supplied with oxygen and blood by the left anterior descending coronary artery. And so if a patient has a big MI and they occlude their left anterior descending coronary artery, it might be that in addition to causing ischemia and infarction of their left ventricle and subsequent left ventricular failure, they won't be able to perfuse the cells that keep the bundle branches working. And you can get a left or right bundle branch block as a result of that occlusion in the coronary artery. Similarly, certain drugs can cause changes in the refractory period and the depolarization physiology of the cells that make up these bundle branch systems. And so you can get permanent or intermittent kind of functional blocks where certain cells aren't functioning, and therefore this whole pathway is affected because of that. And so what do we see on the ECG if we get a bundle branch block? Let's look first. In fact, what we'll do is if we stick another electrode on, essentially when we're trying to recognize or interpret ECG blocks on the ECG, bundle branch blocks on the ECG, and the two leads that we look at are V1 and V6. And that's essentially because as they sit on the chest, they're essentially opposite each other in terms of the two ventricles. And so if we look at both of those, they're the most opposite ones we can look at, and we can see certain patterns on each that can help us work out which branch is blocked, or whether it's just a fascicle. So if we take a right bundle branch block first, the first thing we know, or the first way to recognize that we have a bundle branch block at all, is that the conduction through the myocardium is delayed, and that causes a broad QRS complex over 0.1, about 120 milliseconds, and some texts will say more than 100 or more than 110 or 0.11 is indicative of a bundle branch block. So why is that? Well, if we take the right bundle and assume that there's a block there for some reason, whether functional or anatomical, that's stopping electricity from flowing down the right bundle branch, the left bundle branch, anterior and posterior fascicles, will continue to work, continue to function. And so electricity will flow down them as normal, and it'll be released by the left bundle into this Purkinje network, as well as into the interventricular septum. And so in V6, what we might see is a small deflection. So we see a small deflection as the interventricular septum, as the energy is released into there, as we would with normal function. And then we'll see a positive spike here as the energy is released from the normal Purkinje network into the myocardium of the left ventricle. And then what we might see is, rather than this just small R wave as the right ventricle depolarizes normally, because this bundle branch system can't deliver energy as it normally would, the right ventricle still has to contract. And the way it does that is this cell-to-cell conduction that occurs in the left ventricle has to then feed into the right ventricle. And so we get energy traveling from the left ventricle, from the Purkinje network of the left bundle branch, into the right ventricle, and causing depolarization through this kind of manner. And the important things to be aware of with that is that, because rather than going through this specialized conduction system, which is quick and effective, it's going through cell-to-cell conduction, which is 3 to 5 times slower than the normal conduction system. And so this process is slow, and it causes the R wave to be kind of slurred and prolonged, because it's taking a long time to happen. And so we'll get a prolonged kind of R wave, and it's kind of slurred and it leads to this kind of deep slurred R wave, S wave in V6 before it reaches the ST segment. If we look at V1 then, we can see we've got a normal P wave. And then essentially, because we're looking from the other way, the right bundle isn't doing its thing. And so the first thing we'll see is the interventricular septum having electricity released into it and moving across from the left to the right. And that causes a small but positive R wave in lead V1. I say small because not a lot of energy is traveling across there. And it's quickly taken over or dominated by the energy that's traveling across the left ventricle. And again, because the left ventricle is bigger, although there's probably some energy starting to occur in the right ventricle, there's a lot more and it's in a more amount of tissue. And so what we see, even on V1, is that occurring. And because it's happening, because the electricity is going from the endocardium to the epicardium and away from lead V1, we see a big, deep S wave in this lead. And so similar to V6, once that finishes happening, the right ventricle, which is taking a while to contract because of the cell-to-cell conduction, is still traveling overall with a net direction towards the electrode. And so we get a big kind of broad R wave that occurs in lead 1 prior to meeting this isoelectric line. And so people recognize this classic pattern of a small R, a big R, lead V1, and a big S. And that RSR pattern in V1 is fairly classic of a right bundle branch block. The next thing that occurs is, so we get the left ventricle. So if we're looking at V6, the left ventricle is depolarized normally. And so we should expect to see a concordant T wave because that depolarization has been normal. So concordant T wave in the lateral leads, especially V6. What's normal in a right bundle branch block though, is that in the right ventricle, where this depolarization vector is abnormal, we should see a repolarization vector that is also abnormal because the cells, the order in which the cells have contracted and therefore are repolarizing again is abnormal. And so a discordant T wave is expected in the anterior leads in a right bundle branch block. So what we get, and we'll look at some ECGs shortly, is small r, s, r with a discordant or negative T wave and in V1, and then a deep slurred S wave in V6 as kind of diagnostic factors for right bundle. I'll let everyone kind of have a look at that, screenshot it if you want to, and then I'm going to rub that out and we'll have the same discussion about the left bundle. All right. So that's right bundle branch block. Now let's look at the similar kind of system, pattern, but on the left. So if we imagine, again, we've got some sort of anatomical or functional block of the left bundle branch. There's certain characteristic pattern that we can see, but it occurs slightly differently to the right bundle branch pattern because we know the left bundle is responsible for slightly more complicated stuff, including interventricular septal depolarization and anterior and posterior left ventricular depolarization. So if we start in V1 this time, normal P wave as before. What we'd normally get of this positive spike from the electricity traveling through the interventricular septum doesn't occur because the block normally in left bundle branch block, complete left bundle branch block, is proximal to the Purkinje fibers in the interventricular septum. And so we don't actually see that positive spike because that doesn't occur. The first thing we see is the electricity that's flowed at a normal speed through the right bundle branch is released into the myocardium and follows that normal expected vector towards the electrode in V1. And so we get a big, deep S wave as the energy travels towards the electrode. That's followed by this kind of cell-to-cell conduction. So again, the interventricular septum doesn't depolarize, and none of the left ventricle depolarizes normally because this whole system is knocked out. And so we have this same thing of cell-to-cell conduction through the left ventricle and into the septum happening abnormally compared to how the normal conduction works. And so we can sometimes see a bit of notching in the this deep kind of S wave, which kind of comes up like this, or sometimes it can be just a kind of deep spike that moves into our ST segment. And so we don't really have this big wave of normal function in the left ventricle because that whole system is taken out. And so sometimes we get notching, sometimes we don't, depending on the kind of intricacies of that individual patient's conduction system. And people will recognize from that potentially this this method of remembering William and Marrow, and this W is so that method is William has got 2 L's. That implies left bundle branch. However, like I say, this notching doesn't always occur, and quite often you'll see a left bundle branch block in which V1 doesn't have that W, and so that's personally not a method that I would recommend. If we look at V6 then, normal P wave because the atria are working normally. Again, instead of that little negative spike from the interventricular septal depolarization, and that doesn't occur because it's not happening normally. And so we get a big positive wave in V6 as the energy travels normally through the right ventricle. And then we can get, you can get a bit of a kind of negative deflection in the V6 as the electricity travels into the left ventricle. But commonly, it's a characteristic kind of presentation as a positive wave in V6, again with possible notching, depending on exactly how that's functioning. And again, because this cell-to-cell conduction outside of the conduction system takes a longer time to happen, 3 to 5 times as long, what you get is a QRS prolongation that again meets this criteria of being more than 120 milliseconds or 0.12 seconds. And so if I go back to this presentation, so in summary there, oh, and sorry, I didn't talk about the concordance of the T waves in left bundle, but we can see that, so if we just recap in fact, so on the left there, you can see the right bundle branch block causes in V1 and V2, the kind of right-sided leads, causes this characteristic small r, SR complex with a discordant T wave. And in V5, V6, a tall R wave with a deep slurred S wave and a concordant T wave is classic for right bundle branch block. In the left bundle branch block then, we have in V1, this deep S wave, which may or may not have some notching on it, and then a concordant T wave. And then in V6, essentially the opposite pattern with a tall R wave, maybe with some notching, and a discordant in V1 and in V6 T wave, facing the other way. And that just occurs, like I say, because the repolarization current is abnormal, given the depolarization current before it was abnormal going through this cell-to-cell conduction. So if we, before we look at some ECGs, so that's the kind of classic taught way of recognizing left and right bundle branch. However, there is an easier method which I use personally, and that is this kind of V1 method. So I was taught this by Mark Whitbread, who many people will know, and I'm not sure if it's a method he came up with or he learned from someone else, but it's a very effective and fairly accurate method of recognizing bundle branch block. And so the first thing we need to do is work out how broad the QRS is. If it's longer than 0.12 seconds or 120 milliseconds, we can be, there's other causes for that, but we can start to think that potentially it's a bundle branch block. If it is, if we look at V1 only, we should be able to work out whether it's left or right. And the way to do that is to travel backwards along the QRS complex starting at the end of the T wave, going back over the T wave. And then we can, if you imagine when you're indicating your car, provided you've got a European car, if you're indicating right, you would push the indicator stalk up. And so you have a positive R wave, would indicate a right bundle branch block. Similarly, if you indicate left, you'd push the indicator stalk down. And so a deep S wave, as we see in V1, would indicate a left bundle branch block. And I'll just, if I can stop screen sharing. I'll just draw that quickly for clarity. But essentially, if we have this, so if we draw that pattern of in fact, I'll do V1 here. So we have that pattern that we discussed for right bundle branch block, which is an RSR complex with a discordant T wave. Using this method, so we'd start the further end of the QRS complex, we come back over the T wave. And then if we go up, we'd indicate up, and that would be a right bundle branch. And then if we went down, we'd be indicating left, and that would be a left bundle branch block. And it's useful to kind of have that in your mind, because I have that in your mind as we go through a few examples, because like I say, it's a much easier method to remember and is fairly accurate one, and is the one I tend to use in practice. So if we have a look at a few examples, I don't want to test people, but just as a quick poll, if I told you this is a patient who was a little bit clammy and had some chest pain, what would be the first consideration with this ECG? I'm not showing the screen, so that'll make it difficult for you to see. Is that showing? Okay, so I can't see the answers. But what I'm going to say is, if you said left or right bundle branch block, you may be right, but you may also have fallen into a little trap that I've set intentionally, which is the consideration of VT. So the first rule we have to think of when we're looking at broad QRS complexes is that if the patient is hemodynamically unstable and they have a tachycardia with a broad complex, then unless you're really good at interpreting ECGs, that must be considered to be VT and treated as such. And so it's important, again, to consider that clinical context. So if the patient is hemodynamically unstable, they're clammy, they have chest pain, they're hypotensive, and then their tachycardia with a broad complex is probably VT, and you need to treat for that rather than looking at ECG. It can be a non-VT rhythm with a bundle branch block, but that's much harder to diagnose and is kind of a risky decision to make. But so if we look at some ECGs, so these aren't tachycardic, these aren't VT. So this is an example of left bundle branch block. And so we can see that in lead, so we can see first of all that all the QRS complexes are broad, but also we can see in lead V1 that it's got this negative S wave with a positive T wave, and in V6, this positive R complex with a negative T wave. Similarly, if we just look at V1 and we come backwards over the T wave, we can see that the complex then goes down, which would suggest a left bundle branch block. Again, the same pattern occurs here. Broad complex, negative waves in V1 indicates left bundle branch block. And if we look at this ECG, the opposite occurs. And so this pattern in lead V1 is that small r followed by a big R. And this is a good example that shows that the S wave doesn't have to occur. So sometimes, although RSR complex is the classic view in V1 for a right bundle, sometimes you can just get this RR complex, but then with a negative T wave, which should occur in V1, 2, and 3. And so the reason this patient has a positive T wave, for those that are interested, is because their right bundle branch block has occurred in the setting of an anterior MI. And so this is a STEMI and a right bundle branch block. Let's not dwell on that though. Again, another example of right bundle, and so in lead V1, we can see an RR complex, which is why that's got that weird kind of positive complex in V1, and a deep slurred S wave in V6. So what about treatment then? So there's two kind of presentations that patients tend to have, and one is of cardiac, so chest pain, ischemia, shortness of breath type symptoms, and the other is patients that have a dizzy kind of fainting episode or a transient loss of consciousness. And so if we address the context of cardiac symptoms first, this is the guidelines from the European Society of Cardiology for the management of patients with STEMI. And so the excerpts, my face is over the top of the writing. Here we go. So patients with a clinical suspicion of left bundle branch block should be managed in a similar way to any other STEMI patient, regardless of whether their bundle branch block is known. And so what the guidelines are essentially saying is that it's hard to diagnose ST elevation in the context of bundle branch block. And so if they're symptomatic, treat them as if they're having a STEMI, because you can't say they're not. Interestingly though, and what people are often less aware of, is the same advice goes for right bundle branch block in this context. So if a patient is complaining of chest pain and they look unwell and they're sweaty and pale and a bit hypotensive, that right bundle branch block is equally as concerning as a left bundle in this context, and they should be considered for primary PCI. A follow-up publication which kind of summarized these guidelines, again, kind of made that point that all bundle branch block patterns are considered equal in terms of, in the context of ST elevation, as in they're equally as difficult to recognize ST elevation in. And so considering a primary PCI strategy is important, regardless of whether it's left or right. So this historic thing about left bundle branch block being concerning and right bundle not being is, like I say, historic, and both should be considered as concerning in the context of chest pain and cardiac symptoms. So what the guidelines don't mention is something called Smith modified Scarbosa criteria. They do mention the original Scarbosa criteria. And these are certain criteria that you can apply to an ECG with a left bundle branch block to assess whether the ST elevation is part of that block or is concerning for that patient. And this is an example. So take this example. So this is someone with left bundle branch block and ST elevation. And so we can use this Smith modified criteria, which I'd recommend you go and read up on yourself. But we can kind of apply it here. And this is the paper. The criteria essentially says that concordant ST elevation in the same direction as the QRS complex in any lead over 1 mil is concerning. Concordant ST depression in any lead in the anterior leads is concerning. And a ratio of the ST segment to the entire S wave of more than 25% is also concerning. And so to take that previous ECG, we can apply this criteria and see that in lead 3, there is more than 1 mil of concordant ST elevation, as well as a ratio in V3 of 5 divided by 18, which is more than 25%, i.e. a quarter of 18, 25% of 18 is, what is that, 4.5. And so 5 mil is more than 25%, and that's indicative of this being a STEMI. And so that's just an example, but it's some criteria that's worth kind of looking at if you get the time. So what I'll do in a second is just have a very brief chat about fascicular blocks, because I'm running short of time. But I just wanted to bring your attention to this paper, which is a 27-year retrospective study of patients, 18,000 patients with a baseline of no MI, no heart failure, and essentially a healthy heart. And what they found is that all-cause mortality, cardiovascular mortality, acute MI, and the requirement for a pacemaker were all significantly higher in patients with right bundle branch block. And so this myth, again, it's a myth that right bundle branch block is benign, was disproven by this study and a few others. And so essentially, if a patient presents to you with a right bundle branch block in the context ischemia and chest pain, that is concerning and may indicate a STEMI. But if they present to you with right bundle branch block and not in that context, so in the context of a fall or a dizzy episode, that may also, whilst it's probably not a STEMI, that may also be concerning. And even if that patient is not conveyed to hospital or goes on for further tests, they should be referred for investigation of that bundle branch block, because it will potentially increase their mortality. So I think I've gone on long enough about bundle branch blocks now, I think. And if I dig into fascicular blocks and biofascicular blocks, we may be here for a bit of time. So I might suggest I come back and discuss that another time. But just to summarize this discussion around bundle branch blocks, lost my button. So that shouldn't say learning outcomes, that should say summary. So there's a few kind of summary points to take away. Hold on, that's not the right thing. Here we are. So the summary points to take away are, firstly, that if we're going to look at interpreting bundle branch blocks, the first thing to be aware of is if the patient is tachycardic and they have a broad QRS, what we have to do as clinicians is rule out VT. And that might be easy because the patient is stable and they're known to have a bundle branch block and whatever other reason. But if we haven't considered VT, there's a chance that we're missing it. And if they are in VT, it doesn't matter the pattern of their block. What matters is treating the VT. The next kind of thing is that right bundle branch blocks may be benign, and that's often what we're told. However, there's enough evidence now to say that if the patient has chest pain, is in the context of a potential MI, and that's our differential diagnosis, then right bundle branch should concern us just as much as the left bundle branch block. And similarly, in patients without MI symptoms, who have maybe an incidental finding of right bundle branch, and that's been shown to potentially be correlated with higher mortality across all patients by the Copenhagen study. And yeah, like I say, we didn't get a chance to talk about biofascicular block, but it's something I could potentially discuss in a future webinar. And so that is essentially it in terms of my whistle-stop tour of bundle branch blocks.